Hello, everybody. I am LeAnna Whittall. I'm a physician assistant. I've worked at PBO for the past 16 years with Dr. Stanwood. Go ahead.
Hi, my name is Carissa Wilson. For those of you who don't know me, I've been a PA for 6.5 years with PBOA for the past 1.5 years, working with Dr. Reitmeyer. Welcome. All right, so what's up with my Rotah cup? So for those of you who don't know the local language, we are obviously referring to the rotator cuff muscles, but we often hear some of our patients refer to it as such. And we were actually toying through ideas of what to call this presentation, and I threw this out as a joke. And 3 minutes later, I was CC'd in an email to Dr. Leckie stating this is going to be the title of our presentation. And it was the longest 3 hours of our lives waiting for Dr. Leckie to respond with, sounds good. So here we are. So disclaimer, we have none and no financial interest in the products mentioned in this presentation, but we're currently accepting all offers. Just kidding. So objectives of our talk, we want to talk through just the rotator cuff anatomy, make sure everyone in this room is on the same page, discuss the pathophysiology of rotator cuff injuries, talk through clinical guidelines of rotator cuff treatment and utilization of newer implants that we are using in practice. So you can see this illustration up top. This is the rotator cuff. It's comprised of 4 muscles. These are the dynamic stabilizers of our shoulder. Up top here, I forgot, I got a cool pointer. Up top is the supraspinatus. And so we're all taught in school the mnemonic sits muscles. So that's how we remember the orientation of how these attach and insert onto the greater tuberosity. So supraspinatus is responsible for initiating abduction of the shoulder. Thanks for the choreography. Followed by the infraspinatus and the teres minor for external rotation of our shoulder. And then anteriorly stabilized by the subscapularis muscle here, responsible for that internal rotation of the shoulder. So as you can see in this illustration, supraspinatus sitting up top here is at a higher vulnerability to injury as it sits right underneath that acromion, so putting it at risk of tear related to impingement or repetitive microtrauma for our patients doing a lot of that overhead work. And it makes up about 60% of rotator cuff tears. So rotator cuff pathology makes up the most common cause of shoulder pain that we see in clinical practice. It's estimated about 30% of adult patients over the age of 60 have a rotator cuff tear, whether symptomatic or asymptomatic, and obviously that's going to rise with age. There's a whole spectrum of rotator cuff injury ranging from just tendinitis, from chronic repetitive overuse injury, inflammation, and then extending to actual tears, partial or full thickness tears. And those partial rotator cuff tears do have risk of propagating into full thickness tears related to obviously the size of the tear, but also location. So anterior tears have a higher rate of progressing to full thickness tears and age. So over the age of 60 tend to have a higher likelihood that a partial tear will progress to a full thickness tear. So this is kind of honing in on identifying different types of those partial tears. So you can delineate a partial tear by low grade or high grade. That's just the percentage of vertical thickness of the tear. We can have articular-sided tears. So that's going to be on the articular side near the humeral head. The underside of the rotator cuff tendon tends to be the most common associated with partial tears. And then bursal-sided tears in that subacromial space. And those tend to be actually more painful tears, so patients tend to present earlier in their onset of injury for medical evaluation. We can have intrinsic causes of tendon injury related to just poor vascularity of the tendon, generally in our elderly population, or just the cellular level putting patients at predisposition for tendon injury. And then the more obvious extrinsic causes related to impingement. Like I said, some of that repetitive overuse, or you can have anatomical impingement, which we'll talk about, and then direct injury or trauma to the rotator cuff. This lists out some of the provocative maneuvers that we use in clinical practice when examining patients to try and hone in on where their injury may be and what rotator cuff muscles specifically are impacted. Empty can kind of honing in on the supraspinatus, drop arm test for any global weakness of that rotator cuff, external rotation, leg sign, identifying injury to that infraspinatus, belly press for subscap, hornblower is more for the teres minor. And my colleague here has been voluntold that she will demonstrate any personal direct maneuvers, if anyone's interested, during the break. So imaging techniques. So typically in our office, we start with plain film. So those are x-rays. They're not obviously going to show us any of those soft tissue structures, but it does give us a general idea of what's going on in the shoulder. So showing us any of that anatomical impingement. If you have subacromial bone spurs, that's going to cause some of that impingement and irritation or injury to those rotator cuff tendons, degenerative joint disease, cuff tear arthropathy. We send them to Dr. Stanwood or LeAnna often, and then calcifications, so embedded within the tendon that can also cause significant rotator cuff pathology or pain. Ultrasound, that's going to be user dependent, obviously, in identifying those tears, but is a quick, useful bedside diagnosis if you are able to use the ultrasound in identifying those injuries. So MRI is still our gold standard because it obviously provides a more thorough visualization of the soft tissue structures within the shoulder and identifying those tears. And that's why they say MRIs are the Tinder of diagnostic tools. They can tell you everything that's wrong with you, but can't make any promise that can be fixed. So this was an interesting illustration, kind of correlating how articular-sided partial tear here and what we see on MRI. Fluid tends to light up white on an MRI. And then how we see that arthroscopically with the camera. So again, this is the underside of that rotator cuff tendon. Bursal-sided tear in that subacromial space here. And again, translating that arthroscopically. Interstitial tears, so these are partial tears that are often hidden arthroscopically because that's within the tendon fibers. And those are often identified through feel. Arthroscopically, kind of assessing where you can feel thinning of the rotator cuff tendon. So, what now? So my colleague LeAnna is going to step up and kind of talk through guidelines management and show you some cool things that we're using in the OR. And I apologize because I don't know how to turn down the volume on this, but we've been practicing quiet voices.
I don't have a quiet voice. So these are some guidelines through the AAOS talking about management of treatment, what we do, etc. So we usually start off with non-surgical management, which includes anti-inflammatories, physical therapy, home exercises, activity modifications, and cortisone injections. PT is considered the first-line treatment for small to medium-sized tears, and response to conservative measures typically takes 6 to 12 weeks. If somebody doesn't respond to that, then we have to intervene, obtain an MRI, and discuss surgical intervention. A lot of patients who come in with irreparable rotator cuff tears or have cuff tear arthropathy, then we have to discuss basically a joint replacement with them. I can't see what I need to see, so FYI. If you note the x-ray on the screen is showing you a good example of what a cuff tear arthropathy x-ray looks like. You can see how the joint space is narrowed, has a high riding humeral head, which is an indication that the patient has cuff tear arthropathy and will require a joint replacement. So, surgical management. Surgery options for rotator cuff tears are like IKEA furniture. Lots of tools, some assembly required, and high probability you're going to have a missing screw somewhere. Surgical techniques range from anywhere from minimally invasive techniques for tendinitis up to comprehensive repairs for full thickness or partial thickness tears. Do I have to hit this twice? Thank you. So some of the techniques for treating rotator cuff repairs include the images that you can see. In the bottom right is a biocomposite anchor. We use those for full or partial thickness rotator cuff tears. The middle is an image of a metal anchor, which typically we use that for the subscap repairs because it's easier to manipulate around the lesser tuberosity. or for somebody who has weaker bones. And the video playing on the right, along with the image below, is a Q-fix, which is an all-suture anchor, which we use for our open subpectoral biceps tenodesis repairs. So next, I'm going to talk about the new bioinductive implants. Thank you. So as you can see, the image is of the Regeniten patch, that's a large size one. It's around 30 millimeters. And the video is one of our surgeons implanting that into a patient after a partial thickness rotator cuff tear. Shut up. This patch is designed to promote tendon healing by stimulating tissue growth and offering a supportive matrix of collagen, regeneration, and rotator cuff repairs. As you can see, there are many options. There are other options, but we choose to use the Smith & Nephew one as it has the most data on it to show its effectiveness. On this slide, as you can see, there are the other options, and you can see that the Regeniten patch has a better resorption rate. They have the most studies on its effectiveness, so we kind of stick with that one. Let's drop the microphone. Don't touch. So benefits in using the Regeniten patch. Patients who we put the Regeniten patch in are supposed to have a 50% faster return to daily activities compared to those who undergo a traditional rotator cuff repair. The recovery process is supposed to be quicker with shorter sling times and a faster return to work. And patients usually require less PT visits. On their PT evals, a lot of physical therapists use the ASES and the CMS scores, which tend to improve significantly throughout their recovery time. So overall, the data shows significant benefits to stable full-thickness rotator cuff tears and partial thickness rotator cuff tears. In our practice, we primarily use Regeniten patch for revision rotator cuff repairs and for partial thickness rotator cuff repairs. So we're still accumulating data on its effectiveness, so we're still building that. So there is rotator cuff injuries present in a wide spectrum, and treatment strategies are tailored specifically to the patient's condition and the surgeon's approach. So new advancements, including cutting-edge implants, are expanding for our options for more effective rotator cuff repairs. Recovery periods can vary widely, ranging from 3 to 6 months, depending on extent of the tear and patient's engagement with therapy. The patient's motivation and commitment to physical therapy play crucial roles in their return to normal activities, including work. So this concludes our review on rotator cuff injuries. We want to emphasize the importance of personalized care and patient commitment to physical therapy in their recovery. And this is where we convince our shoulder that no pain, no gain is a real thing and not just a marketing slogan for masochists. These are our references, and we're going to move along here. So Brian, no time for questions.